各位线上贵宾、各位先生、各位女士，大
Ladies
家
and gentlemen, good afternoon. Welcome back to the afternoon session of the impact and response of the medical professional education in the post-pandemic era international online conference. Before we begin, we'd like to remind you that you need to sign in or sign out to receive credits. The first speaker is from Japan. We are very honored to have Dr. Harumi Gomi to give a talk on strategically involving students as collaborators to promote self-directed learning in traditional teacher-centered environment in Japan. We are very honored to have Dr. Shih-Chung Wang from Changhua Christian Hospital as the moderator. Let's welcome Dr. Wang.
Good afternoon, ladies and gentlemen. Thank you very much to continue to join the afternoon session. In this session, we are glad to invite Dr. Harumi Gomi from Japan to share her experiences. Dr. Gomi graduated from Okayama University Medical School, Japan. She obtained a master's degree in public health from Johns Hopkins Bloomberg School of Public Health and a master's degrees in health professions education and a Ph.D. candidate at Maastricht University, the Netherlands. She currently serves as a member of the National Medical Licensure Examination Committee, Ministry of Health and Welfare, Japan, an investigation team member, the National Co-Curriculum Reform Project, Ministry of Education, Japan. In this presentation, Dr. Harumi will share the topic, strategically involving students as collaborators to promote self-directed learning in traditional teacher-centered environment in Japan. Let's welcome Dr. Harumi. Dr. Harumi, please.
Hello, everyone. I'm Harumi Gomi from International University of Health and Welfare. I'd like to talk about strategically involving students as collaborators to promote self-directed learning in traditional teacher-centered environment in Japan. To begin with, I'd like to introduce myself. This is my university, International University of Health and Welfare, which was founded in 2017, strictly for the first time to teach medicine in English. Also, I'd like to briefly introduce myself. I am a physician and a specialist of infectious diseases, and I worked as a volunteer to support Tokyo Olympic Games 2020. I also served as one of the executive board members for the organizing committee for Tokyo Olympic Games 2020. And I visited National Stadium to support those organizing committee members. Today's talk will be as follows. First, I'd like to share the challenges in medical education in East Asian context. And then I'd like to share our institutional solution and reforming processes with the hope that you could utilize some of the hints from our experiences. For your background information in Japanese medical education, in Japan, we provide undergraduate medical education for the duration of 6 years. Mostly students enter at the age of 18 to 20 directly from high school. And after graduation of medical school, all students need to complete mandatory rotating residency for 2 years. Otherwise, you cannot practice. Then most of the graduates go on to the specialty training with a duration of usually 3 to 5 years. As of 2017, there are 81 medical schools in Japan, and each school admits from 90 to 140 students per year. So as a result, we have every year over 9,000 students enter the medical school. And traditionally, since we provide 6 years of undergraduate medical education, 2 years of pre-medical, followed by 2 years of preclinical, then 2 years of clinical education. This is the very traditional format of 6-year undergraduate medical education. However, due to many reasons, recently, most of medical schools provide the following curriculum. Pre-medical and preclinical educations are compressed into 3 years and followed by 2 to 3 years of clinical education. And especially in the final year, most of the private medical schools need to provide preparation period for the national board examinations. Since it's very important for our students to pass the national board examinations, otherwise students cannot practice. This is the brief historical changes in medical education in Japan. Around 1993, problem-based learning was introduced at Tokyo Women's Medical School for the first time in Japan. And during that time, a preclinical clerkship, OSCE, was introduced. Also, clinical education has been underscored and has been emphasized in Japan since then. And early clinical exposures were introduced in most of the medical schools in Japan. In the meantime, after the basic science education, or after a preclinical education, all students need to pass the National Common Achievement Test to go to the clinical clerkship. But at that time, but still, this is not the national board examination. And 2004, major implementation was done. In Japan, we introduced the residency matching system for the all graduates who wish to train in the mandatory residency programs. And 2-year structured mandatory residency programs include internal medicine, surgery, pediatrics, obstetrics and gynecology, and emergency medicine, and other electives. So you must complete the structured mandatory rotating residency programs. Otherwise, you cannot practice in Japan. For newer changes, in 2020, post-clinical clerkship OSCE was introduced in most medical schools. This is part of the diploma policies and a graduation requirement. And students can graduate if you cannot pass the post-clinical clerkship OSCE. And in 2 years, computer-based test, that was the Common Achievement Test. This will become a part of the national board examinations. So all the students, medical students, need to pass this test to become a student doctor to retain the clerkship training on the wards or in the hospitals. And this is a big change, and a student doctor will obtain a legal status to train in clinical medicine in Japan. In the meantime, we have gender gap issues, and this is the graph showing the proportion of female medical students per year. And at the moment, we have almost 40% of female students in entire Japan. This is the background information in Japanese medical education. And now I'd like to share our challenges and new trials in our institution. There is a big issue in terms of the integration of the curriculum. This is the degree of curriculum integration. Each character stands for the discipline-based, and basic and clinical education are separated. And N stands for some integration occurs at an early stage, and basic science and clinical medicine were both taught at the beginning. And spiral curriculum, this is thought to be ideal. Basic and clinical medicine will be integrated and repeated and reviewed by the students throughout the curriculum. In terms of the integration, this is the data for the prevalence of problem-based learning in Japan as of 2005, almost 16 years ago. And at that time, about 1/5 of medical schools did not introduce problem-based learning. And on the other hand, almost about the same proportion, 1/5 of medical schools introduced full problem-based learning sessions over about 60 weeks per their curriculum. And now I'd like to talk about outcome-based education. In the era of outcome-based education, OBE, CAMMES 2007 and 2015 have been utilized worldwide. And this outcome-based curriculum was a big shift in terms of designing medical school curriculum, especially in East Asian context. Traditionally, a teacher-centered curriculum was very prevalent, and from faculty-centered to student-centered shift was a big change. And previously, faculty teach what? But in student-centered curriculum, students need to learn what and does. And instead of knowledge-driven, outcome or competency-driven curriculum needs to be designed, and from discipline-based to problem-based, and from structured learning to the opportunistic learning. That was a big change. And in Japan, we are still in the process of shifting from faculty-centered to student-centered. This is the model core curriculum that was defined in 2016 by the Ministry of Education in Japan, and there are 9 domains. And most of the domains are similar to the CAMMES and other competency model, such as ACGME model. And on the basis of the core curriculum, each medical school in Japan need to design or reform the curriculum. For example, in our medical school, we have 4 diploma policies, diploma policy 1, 2, 3, 4. And based on that, we need to design each course along with the competencies. We have 21 competencies, and that was also defined by the Ministry of Education, and we need to provide students with these competencies. And then we need to assess those competencies using the Mirror's pyramid, as you know, from knows to the does. In terms of the quality control, each medical school in Japan need to pass the accreditation criteria. We have an agency called JACME, Japan Accreditation Council for Medical Education. And then for the quality improvement items, there are 2 items for integration. Basic sciences need to be integrated, and basic and clinical education need to be integrated. These are very difficult for most of the medical schools in Japan, but we are trying very hard. Why integration is needed? There is some scientific background. There are some components for better memory retention and effective retrieval, especially retrieval in the workplace for medical students. And if you provide context for application of each knowledge, students will hopefully effectively retrieve other knowledge when needed. So therefore, contextual learning should be promoted to promote easier theory transfer for our students. Again, coming back to the SPICES model provided by Dr. Harden back in 1984, from discipline-based and information gathering to problem-based and integrated learning need to be provided. There are some pros and cons. if we provide very structured learning, these are mostly preclinical education, and in terms of time frame-wise, in that case, usually time fixed. But towards the clinical education, students learning can be opportunistic on the basis of the patient encounter, and then they're highly student-centered, and then it can be a time flexible. So this framework clearly describe the pros and cons of a structured learning versus opportunistic learning, and preclinical education versus clinical education. And we can keep this frame in mind when we design the curriculum, both for preclinical and clinical education. Now, I'd like to talk about the outcomes of problem-based learning. This is the outcomes of problem-based learning on the basis of the 22 years of research. This study was published in 2010. And in this paper concluded that problem-based learning was studied mostly in curriculum-wise, but 30 studies were included, but unfortunately 30 studies did not provide unequivocal support for enhanced learning in problem-based learning compared to the traditional curriculum. There are some reasons. One is that studies are there are many heterogeneities, and there are methodological limitations and assessment problems or measurement problems. So therefore, this systematic review was not able to provide the effectiveness or superiority in enhancing learning in problem-based learning compared to the traditional curriculum. I'd like to also show you some local data. Problem-based learning has been introduced since the 1990s in Japan, but prevalence is still relatively low in Japan. But there are some studies showing some effectiveness, especially the effectiveness of student tutor and student involvement. In Saga Medical University, student tutor was highly appreciated by the students, and this is a promising result to get involved, to have students involved as a collaborator. Another study showing students' perspectives in changing a curriculum, and this study was performed at Vanderbilt University, and I thought this is a very interesting report to know the students' perspectives. At the Vanderbilt University, they reformed their curriculum from 2006 to 2013, and they compressed the basic science education from 24 months to 13 months. And core curriculum starts at year 2, and because of the shorter basic science education. And striking findings were as follows. From students' perspectives, due to the shorter duration of basic science, they felt that basic science knowledge might not be sufficient. And for the spiral curriculum, they thought that the same content were repeated, and then they thought that was the repetition, and did not think that those were necessary for them to review. So it was I thought it's very interesting to know the students' perspectives, and then definitely have students involved when reforming or implementing a new curriculum. And another recent study that was published in 2013, this is a study from Indian Medical School, and they changed from traditional curriculum to the problem-based learning and more integrated format. And then students did actually well when they were assessed. Especially in our medical school, we teach anatomy, physiology, and biochemistry, that kind of discipline-based. And then it has been very tough to convince and to get involved faculty members for the integration movement. So therefore, this is one of the evidence that those integration would support students' learning. So there are several integrated teaching format, and traditionally problem-based learning and team-based learning and case-based learning. Regardless of the teaching format, integration itself is very important for our students to acquire necessary knowledge and to be retrieved in workplace for the effective patient care. So therefore, I'd like to share the directions to go to. We need to share the vision and social accountabilities to provide better patient care. And then we need to promote faculty initiatives. Top-down approach may not work. It's very important to have the faculty to initiate, to improve, and to provide better curriculum. And then most importantly, we need to get students involved as collaborators when reforming or when implementing a new curriculum. Then we need to nurture collective will for integration or to implement better curriculum. And then we need to reflect ourselves using the organizational self-assessment of the curriculum. And then as a very strong outside driving force, the accreditation agency is there, and we need to pass the accreditation criteria to get approved. Now I'd like to move to the degree of integration. The degree of integration are divided into either class-based, course-based, or curriculum-based, and there are pros and cons. And especially in Japanese medical schools, for basic sciences, we provide mostly a discipline-based curriculum, but we provide discipline-based curriculum. We need to face with the serious problem of curriculum hypertrophy. Each discipline tries to provide a lot of information, and then that leads to the condition called covaritis or curriculum hypertrophy. Then we move towards the integration, either problem-based, team-based, or case-based. It's a challenge to promote students' motivation. At the beginning, as I mentioned, our students are from high school, and they are very used to passive learning, passive way of learning, and a random memorization and factual recall type tests having prevailed. So therefore, each student needs training for self-direct learning. And we need to avoid or prevent insufficient knowledge acquisition through the problem-based or team-based or case-based integrated curriculum to pass the national board examinations. So in our institution, to face those challenges, this is one of the trial to promote both horizontal and vertical integration of the curriculum. In the era of COVID-19, video learning has become a very routine and easy provision for now. So therefore, short asynchronous video learning at home for our students, and then when they come to face-to-face sessions, we can provide very short review lectures and provide quizzes, and then we can provide a Q&A session. Then periodically, we can also provide integrated sessions using either problem-based, team-based, or case-based. Then on top of that, we need to provide periodical, consistent, integrated assessment for our students. So this is a conceptual scheme showing the teaching format that I mentioned. So there is a unit for either organ-based or problem-based, and then after probably like 12 classes or so, 1 to 2 integrated sessions can be provided in our institution, for example. So each medical school or each in your medical school, in your institution, you can think of those periodical integrated sessions if you provide discipline-based curriculum for preclinical education. This slide shows the viewpoints of constructivism. This is sort of a summary slide for my talk. In current medical education, outcome-based education is a trend. And to support those curriculum, or to support, or as a rational, that kind of trend, there is a strong rational in terms of the constructivism. Those are student-centered curriculum and self-directed learning, and either problem-based or team-based, case-based integrated curriculum. And if you provide student-centered self-directed learning, assessment can be a programmatic assessment, and you can provide periodical formative feedback for the improvement for your students. And then to achieve the designed outcomes or competencies, time should be flexible, because otherwise the students may not be sufficient enough to graduate in terms of knowledge and skills. And at the end, I'd like to share my dream medical school. If I could make the ideal medical school, I'd like to design as follows. In preclinical education, I'd like to provide a real patient encounter, and students can learn significantly in workplace at an early stage. And then to provide self-directed or instructed learning, 4 to 6 proportion can be provided. 4 face-to-face faculty session with a 60% self-directed or instructed self-study. And then we can provide more individualized adaptive curriculum for each student. And then to achieve the goals of competencies, time needs to be flexible. So as your take-home message, to reform and to improve the curriculum, students are the key, and get students involved as collaborators. This is the photo of my very first graduates, class of 2006. They are always my motivation, and I'd like to continue to improve the curriculum and provide better education in my country. And I hope that my talk will be helpful in your institution or in your context. Thank you very much for your attention.
Thank you very much, Dr. Harumi. Thanks for your excellent presentation. It's time open for the audience. Is there any question from the audience? Okay. Dr. Harumi,
Yes.
may I ask you a question?
Yes, please.
Yeah. We all know a successful integrated curriculum also involves input from teachers from all different disciplines. In Taiwan, we will encounter some teachers are reluctant to put the time and the effort into changing what they already do in the classroom. Yeah, and it is often a difficult task to coordinate schedules and agreement on ideas across a variety of teachers. Can you share some experience in Japan about teachers involved in the integrated curriculum?
Sure. Thank you very much for your question. Well, as I mentioned, in our country, faculties are in general enthusiastic. However, it's very hard to get together because of the silo systems, because each discipline works separately. So in our institution, we try to get together through the faculty development programs, although including myself, it's hard to attend due to the time constraint. So I think that I believe that we need to have some innovation for faculty development to get together, to think about better curriculum and better educational format, and to provide a better student outcomes, I believe. And then this is not only the national problems, but like this, throughout the countries, with the different countries, we can get together and share ideas, and then to move forward to provide better student learning, I think.
Okay, thank you. And another question. The student motivation is very important in the program of integrated curriculum. How do you to inspire the student to get involved in the program?
Okay, I can share our institutional experience. Maybe your programs have this same strategy, but each course in our institution, we have so-called teaching assistants. So student can serve as a supporter of the teacher of the course. So several students get highly involved in kind of adjusting the course during the course. Currently, I teach third-year medical students, that is the preclinical year students. And then I have several students to give me the direct feedback from the entire class. We have 140 students in one class, and then those teaching assistants can collect the students' wishes or the opinions, and then they gave me those opinions or suggestions. Then I can, in real time, I can adjust the course. That is the example, sort of.
Thank you very much. Very impressive and inspiring from your talk. Okay. Because of time limit, I think I have to close this section. And I hope we can meet Dr. Harumi in person in the near future. And thanks by this chance, thanks for Japan to donate the vaccines to Taiwan. Thank you very much. And okay. take care and stay safe. And thank you again, Dr. Harumi.
Thank you, Dr.
Thank you very
Wang.
much.
Thank you for your moderator. Thank you so much.
Thank you. Bye-bye.
Bye-bye.
Okay.
我们谢谢 Harumi Gomi
Thank
博
you
士。
very much, Dr. Harumi and Dr. Wang. The second session in the afternoon, we are very honored to have two speakers from Thailand. The first one is Dr. Sesman from Ministry of Public Health. The topic is nursing attributes and competency uplifting in Thai healthcare system in the post-pandemic era. The second speaker is Assistant Professor Dr. Nathan. The topic is challenges and prospects of the nursing education in the post-pandemic era in Thailand. In this session, we are very honored to have Dr. Nila Gao, CEO of Overseas Medical Mission Center, to introduce the speakers and chair the Q&A session. Let's welcome Dr. Gao.
Good afternoon, ladies and gentlemen. In this session, it's our great pleasure to invite two speakers from Thailand to share their experience. The first speaker is Dr. Sasamum, and she is the Senior Nursing Technical Officer of Nursing Division of Ministry of Health of Thailand. And Dr. Sasamum, Dr. Sasamum has more than 15 years of experience as a nursing lecturer and worked as a technical public health officer at the Department of Disease Control for 5 years. And during the pandemic, she is appointed as a member of Nursing Collaboration Center for COVID-19. So in this session, Dr. Sasamum will share nursing attributes and competency uplifted in Thai healthcare system in the post-pandemic era. So let's welcome Dr. Sasamum.
The topic is nursing attribute and competency uplifted in Thai healthcare system in the post-pandemic era. The outlines will focus on response and impact of the COVID-19 pandemic, policy recommendation, lesson learned, and conclusion. Let's begin with the COVID-19 cases in Thailand. At the beginning of the pandemic on January last year, we effectively lowered the COVID-19 cases. But by mid-December last year until now, we face various challenges on fighting against the COVID-19. As you can see that the number of new infected cases has been increased. However, the number is quite stable right now. And the mass vaccination does cover around 50% of the Thai population. Therefore, we probably can say that management of the COVID-19 pandemic in Thailand is gradually succeeding. So what we do at nurses in response to the COVID-19 pandemic? The nursing division has set up the Nursing Collaboration Center for COVID-19, NCC, that works through the Nursing Division Network platform, as shown in the slide. NCC and the Nursing Division staff work through a strong Chief Nurse Officer network, including both Unite with Thailand Nursing Council and Nursing Associations of Thailand, who manage the COVID-19 cases in the country. Working channels include group lines, Facebook, Twitter, phone, and face-to-face meeting. But with COVID-19, we repair to webinar and can say that we learn various digital technologies, so the digital skill has been improved. Managing the COVID-19 situation will be divided into 4 phases as shown in the slide. What does the NCC Act? We establish and implement measures to handle the COVID-19 situation. For example, guidelines on nursing manpower management in the COVID-19 situation, guideline on management of vaccination services, manual on nursing administration in the COVID-19 outbreak, and manual on discharge planning for the COVID-19 patients, summary reports, 13 video trainings, and 14 infographics on PPE wearing and washing COVID-19 patient care. For example, intubation, airway management for patients with suspected or confirmed cases. Working channels include webinar conference, channel for listening, Q&A dialogue. The major impact on nursing and professional population include policy and direction of the nursing services management. We take off a clear policy and position on workforce planning. For example, mobilize the existing healthcare staff and healthcare facility, minimize immediate stress on healthcare workers and critical care resources, and allow time to scale up healthcare workforce capacity and other necessary equipment. We also escalate to Special Nursing Emergency Operations Center, EOC, in the nursing organization colleagues to set up contingency plan and do exercise of the COVID-19 that can apply to another emergency and disaster situations as well. Safety and supportive measures include hotline for mental health supported by Department of Mental Health, offering civil servant position to new graduated nurses, financial support, for example, adverse event has this compensation to healthcare workers who work with the COVID-19 cases and COVID-19 insurance coverage, supervision, monitoring, and collaboration mechanisms operates through Nursing Division CNO network platform with various working channels consisted of webinar, group lines, Q&A, dialogue, various nursing knowledge and technology development and dissemination as mentioned previously. Policy recommendation includes restructuring of the nursing administration that assign nurse managers to work in different settings of the COVID-19 services. For example, frontline and surveillance in the OPD and ARI clinic, treatment and procedures, and caring for the COVID-19 cases in IPD and ICU units. Healthcare staff in relation to types of the COVID-19 patients. We divided the patient into 3 categories: red, severe symptom, yellow, moderate symptom, green, mild symptoms. The proportions of nurse staff mix and the patients shown in the table. Staff mix include nurse assistant, army medical staff, public health officer, paramedics, and lab scientists to collect specimen in proportions of 1 scientist and patient is 1 to 100. We also do shift arranging. We do 12 hours instead of 8-hour shifts that can reduce nursing staff to nearly 25%. We also conduct a research on development of nursing administrative model in the COVID-19 outbreak situation between November 2020 till March 2021, using concept of 7S, Jennings Disaster Nursing Management, and 2P2R framework of the EOC implementation. The result shows that the developed nursing administration is very useful and very practical in any pandemic situation. The proposed model consists of 3 components: nursing EOC, readiness assessment of the nursing management in COVID-19 situation, guideline for nursing management in the COVID-19 situations. Therefore, lesson learned from the NCC working and the research indicate that attributes and competency uplift of the nurses include professional skill competency, for example, infectious control, universal health, precaution, self-improvements, for example, growth mindset, positive thinking, ICT literacy. Social skills include effective communication, and active listening, relationship and conflict management, respect and sharing. For leadership development include agility, adaptability, conflict management, and negotiation, emotional and cultural intelligence, delegations, and team building, with positive feedback, motivation, way of thinking, working, and living include critical thinking, problem solving, initiative, and flexibility, information and media literacy, personal and social responsibility, and citizenship. In conclusion, effective COVID-19 nursing management includes leadership, preparation, collaborations, and participation, and effective communication. Finally, I would like to close this session with recap words. When faced with unexpected situation, don't panic, be prepared and ready, keep practicing, and we will pass this crisis together. Thank you. Any questions?
Thank you very much for Dr. Sasamon's sharing. So in this session, the second speaker is Dr. Nasafen. Dr. Nang is an assistant professor and the former dean of the Faculty of Nursing Science at Assumption University of Thailand. She currently serves as the executive board of the Nursing Association of Thailand for international affairs and leadership initiatives. So her research area is in social empowerment of women, experience of sexual violence, and health-related issues. So she is dedicated to women's rights advocacy in the workplace and the pioneer research of date rape issues with Thai college students. So in this session, Dr. Nang will talk about the reframing nursing education in the COVID-19 new normal Thailand experiences. Dr. Nang, please, the floor is yours.
Good afternoon, everyone. It's my great pleasure to be with you this afternoon. I would like to thank you, Dr. Nina, for your kind introduction. Today, I'm happy to share with you about the reframing nursing education in the COVID-19 new normal. We all know that COVID-19 pandemic affected to humanity. We face a lot of changes, including global policy, country policy, health system and service change, social system change, industrial system also change, economic also affected. So individual person have to change a lot about their daily life, work, and education. So we are transformed, we are moving from normal to new normal or even new era. Nursing education is not immune, so we affected by COVID-19 as well. And conforming to the government measurement of lockdown, health professional education or nursing and training institution has to close down, leading to the student limit access to learning facility and resources. So the class lecture has been converted to various distant learning approach. Clinical training also need to be suspended, and the clinical placement also interrupted. Because of health professional education or nursing education related to health system and broader community, because we send our students to practice there. So because of lockdown, because of close down of the school, students experience a lot of obstacles and limit access to learning facility and resources. So clinical training has been suspended and also interrupt of the placement and internship. Because of lockdown, school closed, the students have to stay online education. Teachers have to work from home and online working, including meeting and so on. So we know that communication with the student are very important. So we worry about the student, that how much they learn. According to the education system of the country, need to be altered. Nursing education need to be transformed, and a lot of technology has been used, and the learning outcome is focused because we would like to ensure that our students will be ready for the transformed nursing service after COVID-19. There are selected online applications for online learning platform that need a lot of investment for education resource by the school and university. Learning resource center need to transform to be virtual, and the existing nursing simulation need to be think about how can we provide virtually. We provide the student with e-library, e-journal, and e-books. And some modern technology also can enhance learning of the nursing student and improve their achievement regardless of their location. Some schools use open learning platform, MOOCs and Moodle, and Zoom and Microsoft Teams, and some Facebook, social media, Line, WeChat, and so on. I believe that in your country also use the same. Key learning approach include blended learning, remote learning, interactive learning, synchronous and asynchronous learning, virtual reality, flipped learning, simulation scenario, webinar, cooperating learning, and even live stream classes. For the blended learning, we blend between face-to-face learning via virtual and online learning by themselves, synchronous and asynchronous. That means at the same time, and the course may be available for the student to learn by their own for their time, their available time. Virtual reality also provide in some school so that the student can learn from the virtual reality, experience some model and some simulation, the same as they can touch the 4D dimension. For nursing education, we need to do the new policy and recommendation. There are two inputs at least from our country. The first one is from the Global Interprofessional Education Conference. And the second one is from the Transforming Nursing Education in Changing Healthcare System, conducted by Thailand Nursing and Midwifery Council during August 13 to 14. And for the institution or university, they should have the response in terms of set up the adaptation policy, curriculum redesign, learning outcome focus, and nursing focus on the desired nursing graduate for the 21st century indicator. For the Thailand Nursing and Midwifery Council, which is the nursing regulatory body, we have a response in terms of set up the new nursing policy, change the indicator, standard, some guideline for new curriculum quality assurance, teaching and learning quality assurance, nursing research and innovation criteria, accreditation of the institution. A lot of guideline and indicator has been changed, and new nursing standard and CNPG for the COVID-19 patient, new nursing competency reconsider and change to fit the new situation. For the expected learning outcome, we expect that our new generation of nurses to have the critical thinking, problem solving credible, ethically and skillfully in taking care of the patient in order to adapt to the new health system. For the Thailand Nursing Council recommendation, all the schools will have to start thinking about entrustable professional activity. There are 5 levels that are proposed by the Thailand Nursing and Midwifery Council. That for the level 1, they use the hybrid learning. The student will be encouraged to learn knowledge and also but they cannot practice. So the observation in clinical setting or video are provided. For the level 2, use hybrid practicum. Student will have the hand-on practice that need the teacher for the course supervision in the Learning Resource Center and Simulation Lab. But during COVID-19, hand-on practice is very limited. For the level 3, hybrid practice, virtual and on-site, self-practice that still need facilitator. The teacher will change their role from teacher to be the facilitator. So the distance supervision using online scenario are used. And for the level 4, self-practice alone by the student for the self-directed learning. So the hybrid self-directed practice in the virtual or online, the on-site will be provided. But the high expectation is on the level 5, the student should be able to teach or monitor junior student during practice. So self-directed learning with distant consultation with the teacher are required. So this is a picture that the teacher used for the level 1 and 2 for the demonstration. And the student also can do the self-practice alone with the monitor and supervision by the teacher and consultation by the teacher. And the student also will be able to practice alone, okay, and with the junior student or senior student can monitor the junior student and also the sophomore student. So this is a skill that we need our student to have it, okay. Under the COVID-19 emergency, the learning has been changed as I mentioned earlier. So the student-patient engagement is still necessary. Nursing students, some of them are struggle to complete the minimal requirement in clinical placement. So we try to help them. So we redesign the practicum schedule. For the assessment modality, we need to redesign in order to make sure that we can assess the competency-based education and to make sure that they are not delayed or in examination. Some school might use the previous summative and formative performance to enable award of the degree. Teachers have conduct remote to take the test online and using IT technology. And you know what, we have to prevent the cheating of the examination. So remote live proctors are necessary. Some schools might use biometric-based proctoring. And there are challenges in teaching physical examination that we still think that how can we make sure the student can practice physical examination via the video or in the group with the introduction by the preceptor and followed by the critical discussion. To take disadvantage of the COVID-19 circumstances, we also need to help the student to practice in the healthcare setting with the supervision, course supervision of the teacher. Student time in clinical practice can be used to support achievement of the practice out in order to graduate. There are some challenges, as we know that the students have to adapt themselves in various teaching innovation, and the faculty also have to adapt themselves in order to use the technology proficiently. Some students also need to take cross supervision because students learning under the less direct contact and supervision than in the face-to-face, they might feel bored or didn't motivated and stay engaged in the online classes. Some health professional students could not access internet, and that is a problem as well. Regarding assessment, as I mentioned earlier, some of them also face with cheating. Okay, so we have to resolve those problems. So some challenge in terms of new developed curriculum. This one, they need to get the curriculum accreditation by the Thailand Nursing and Midwifery Council. That's why I mentioned earlier that they need to have the new indicator. Another thing is the challenge is the anxiety of the student related to delay graduation, to fulfill learning milestone, about the register to practice. Now they are worried about how better they can get the license, they can pass the license examination. And also, they also worry about the quality of education. There are some recommendations for all of you that nurse educator must take the lead in this initiative. They need to reset the mindset, and digital technology skill also need to enhance. A long-term plan must be done collaboratively with nursing service. In case that the student cannot practice in the full steam, we need to collaborate with the nursing service to set up the enrichment center to facilitate newly graduate nurses to refresh their knowledge, reskill and upskill to ensure that they can work well in the new normal health system. For other recommendation is about our stakeholder need to help, to cooperate in this movement, and government also need to support fund for the school to invest more for the technology. During this transition, we know that we have the workforce shortage, so aging workforce in service and education should be reconsidered. Public-private partnership and interprofessional education must be strengthened and rekindled. So this is all for my presentation. I'm happy to entertain some questions from the participants. So thank you very much for your attention. So Dr. Nina, I'll get back to you.
Thank you very much for Dr. Nang. And once again, thank you for our two speakers in this session. And so now it's open for Q&A session. Yeah, any question from our audience? Yeah, before we collect the question, I want to ask two of our speakers. So during the pandemic, I think in Taiwan and Thailand, we have the same problem. Many nurses want to resign from the hospital because of the heavy workloading and the security concerns. So the leader of the nurse association or the government officer, what's your strategy to keep the nurse human resources and the incentive to encourage them? So maybe May, you can respond to the question first, then later now you will respond to the question. May, please. May, you have to turn on your microphone. We couldn't hear you. Okay, please.
Thank you, Dr. Nina. Sorry.
Yeah,
I think
go
it's
ahead.
the nurses in Thailand, they work with a heart, and then they're willing to help in crisis event. I think it's for us, we do have many various supportive measures. For example, working facility management, make their dorm like a home or something, make their staff in the unit like a home. We provide everything for them. Boarding house, food supply, and shower room. And then sometimes we do a formal and informal visit to cheer them up. Financial support, various stuff like adverse event or hazardous compensation, COVID-19 insurance, and additional quota for double step annual salary adjustment. Sometimes we do have like government position, offer a government position for the new graduate nurses, or sometimes get promotion. And for remedies measures, we do workforce management, like pooling experience of the nursing staff, team staff location, and then shift arrangement. For example, instead of 8 hours, we do a 12-hour shift. That can make use staff, carry the nursing staff up to nearly 25%. That means they have more day off for them. And then we providing safety working condition, and then we do a vaccination for the healthcare staff first. Provide adequate PPE supply, unit modification for them to work with comfortable, and many trainings and various training on the IC and other related issue, like practice in the ICU, intubation, or I think it's AI clinic or something like that. And then we have COVID information and various skill training for them. And in Thai society, we do have kind of like social recognition for the nurses when they do a care for the COVID-19 patient. It's kind of like social favor for them. And then they feel good that they can do something to our society. Thank you.
Thank you. How about Nang? Yeah, you are the executive director of the Nursing Association of Thailand. I think maybe you receive many of the complaints from the nurse. Yeah, so how's your management? Yeah.
Okay, thank you for your question. I think this question is very interesting, and May already mentioned some point. On behalf of the executive board of the Nurses Association, I think so. Actually, we didn't receive so many complaints, but we also concerned about whether they resign from the job or not. But in terms of Nurses Association, because we deal directly with their welfare, okay? So the first thing that we try to let them know about the progress of their works in order to enhance their morale of working. So we let them know that actually May know already about this because government provide a permanent position for them. I think about 15,000 position. In the past, we fight a lot in order to let them have permanent position so that they can get the free benefit. But during COVID-19, so Nurses Association just, provide consultation and say that, right now, government already provide the permanent position, so don't leave, okay, we have to stay. And the second thing, we know that they have the health and life insurance for them. So whatever they feel secure if they get infection or anything. And also, we also urge the government to give them the remedy fund in case they get infection or die on duty. So the president of the Nurses Association already make appointment to see the Minister of Health, okay, so that we can, propose about this thing for our members. Another thing that we try to raise the self-esteem, as May mentioned about we praise them, we provide a channel to let them know that the public already recognize the contribution and also let them feel good about their work and their contribution. We call them hero, we call them, frontline hero, something like that. So in the past, we know that we have a lot of problem about try to increase the good image of nurse. But during 2020 until 2021, I don't want to thank to COVID-19, okay? But luckily, the public already provide and give a good recognition to nursing profession because we are in the spotlight and everyone see that nurse contribute a lot. That's why we try to bring this one up and, praise them and let them know that don't leave, you already in the good position, you already in the good way to contribute to the society, those kind of things. That is what we have done, okay? I believe that the number of nurses who resign from the job is not different from the normal situation right now. As May mentioned that we try so hard to keep them in the system. So that is all. Thank you.
Thank you. So because most of your policy or your incentive strategy, maybe most of them for the public hospital, because the public hospital in Thai, they play a very important role to care of the COVID-19 patients. So I would like to ask another question is, how about the private hospital? Yeah, do the government any of the incentive or strategy for private hospitals and nurses, or you incorporate all of the nurses, not no matter they from public or private hospital, you care all of them. So what is this? Yeah, Nang, maybe you can answer.
Actually, both private and both public, from the Nurses Association, we treat them the same. Actually, we also provide the same measure. And even the nurse who are not the member of Nurses Association, when they get sick, get infected, we also have the money to visit them. And, if unluckily they pass away, we also have the fund for the family as well. This is from Nurses Association. Yeah. More different actually.
Okay. So the last question is, for some of nurses, maybe they need to stay at ICU to care of the acute patient for the COVID-19 positive, even of duty. Some of them maybe they don't want to go home because concern of the infection to their families. So do you have any of strategy to management or care of those of the nurses for their psychological issues? Yeah, none. Will you answer, or May will I answer?
Okay. Actually,
Okay.
okay. Let me first. Yeah.
Okay. For me, I think is the way is kind of like encouraging and then motivated them that now during this situation we have many things come along with working very hard with the COVID-19. Now nurses in Thailand, I think is in the government site. We have various channels for career advancement for them. And then we have to keep encouraging them and then reassure and ensure that on the safety measures, they have to do kind of like practice. And then we have to ensure safety environment and safety working condition for them, including provide psychological support through various channels, telephone, meeting, or the hotline for them in order to get the tensions off. Thank you.
Yeah. No,
I think,
Professor?
yeah, I think almost the same. But actually, from the Nurses Association, we know that, and also some private hospital, they provide a group debriefment. Group debriefment is mean they can get together in a group, and not maybe via Zoom or via Line, in order to mutual support. And the leader of the organization will take, participate in this session as well, in order to hear them, what about their concern and those kind of things. And the second thing is most of the private hospital, they provide, and also I believe that also the public hospital also provide the place, condominium or, hotel for them to stay, so that they don't have to be worried about the place, that they have to give them the, physical convenience. They can sleep well, before they go back to fight with COVID-19, those kind of things. And the mental health department of the Ministry of Public Health also provide the counseling program for the health personnel as well. So the nurse also can use that channel. They provide for the general people also, but for the health personnel, they also provide this kind of program. So we encourage them to know the channel, how can they reach this kind of facility. That is what we have done. And in terms of Nurses Association, as I mentioned to you, that when they get sick or anything, the Nurses Association will have the visiting kit to send them the message that we are, along with you. We know that what you have done. And in terms of their worry about their family or those kind of things, as mentioned by May, that they already get vaccine. And as I know that the family of the health personnel also can get, the channel to get vaccine before other general population. Okay, that is all that we try to help them. Okay.
Thank you very much. Thank you for your join. Yeah, so I think the time is almost up. Once again, to thank you, May and Nam, to join us today. And I wish that we can see you again very soon in Thailand. So thank you very much. Thank you. Bye.
Bye.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Bye.
我们谢谢萨萨蒙博士。
Thank you very much. We also thank Dr. Gao for moderating the session. Next session, we are very honored to have Professor Vura, Dean of the Nursing School from Walala University. The topic, the nursing education in the post-pandemic era. The moderator is CEO of Overseas Medical Mission Center, Dr. Gao. She will also chair the Q&A session. Let's welcome Dr. Gao.
Hey, Samadika again. I'm continuing to moderate this session, so it is also a great pleasure to invite Dr. Urai from Walala University of Thailand to share her experience. Dr. Urai is currently the Dean of School Nursing at Walala University, Thailand, and she has extensive experience in leadership and nursing management, health promotion, public health system, and so on. So Dr. Urai is committed to promote cooperation between the citizens and the public-private sectors to enhance the community-based health promotion. Her talk today is nursing education in the post-pandemic era. Dr. Urai, the floor is yours.
Good afternoon, all attendees in this meeting. I am Urai Jaleprapan, Dean of School of Nursing, Walala University. It's a pleasure to have you with us in this presentation. So let me share screen my presentation. Before we talk about nursing education in the post-pandemic era, may I introduce Walala University and our nursing school with this video.
瓦莱兰大学位于泰国洛坤府。
Walala University is located in South Thailand. It occupies 21,000 square meters. This is a very prestigious university. This is an economic and administrative center in South Thailand. It also has a very beautiful scenery, waterfalls, high mountains, beaches, the ocean. Phuket Island is also within the proximity of their university. This is a national park. It's a great combination of civilization and Mother Nature. Under the leadership of President Somba, Walala University has embarked on aggressive reform. It is marching toward a new era. Walala University has over 90% students passing the licensing or certification, and the employment rate in 2017 is reaching 97.4%. We are very proud of this achievement. We also have introduced UK professional standards framework for teaching and accreditation. The purpose is to build a proactive learning environment. We also have an active learning classroom, smart classroom. The university is also focused on English teaching. 90% of the graduate school professors are from English-speaking country. With the language proficiency, the students after graduation have become the more competitive. We have 13 schools that covered health, natural, and the social sciences, covering the 42 disciplines. We also provide a smart classroom, smart lab, and photovoltaic vehicles on our campus, as well as a lot of the training settings. The health of students and the faculty is also very important. So we have the fitness center, sports center, tennis court, badminton court, swimming pools. This is the Wang University Hospital. It served the community member. It occupies 970 acres. It provides 750 beds, serving more than 1 million people. It will become fully operational by 2021. We are also the first-class research university producing outstanding R&D result in 2019. We ranked number 7 in the Chicago, the ranking. We published more than 1,000 papers. We have 17 professional graduate institutes working on scientific research and development in line with Thailand 4.0, the strategic program. Change never stopped. We'll continue to commit to enhance the quality of education.
And then let me introduce our School of Nursing, Walayalak University, with this video, which we call Open the Door to Real Experience of the School of Nursing, Walayalak University.
Hypodermic syringe, pressure gauge, AED, cardiopulmonary resuscitation, intensive care unit, patients, patient rooms. There are many ways to describe the learning environments at School of Nursing. We focus on producing graduated who are talented and productive people. This focus is supported by the variety and available learning process. These processes encourage students systematically as they acquire practical knowledge in nursing science. As a result, Walayalak nursing students develop into valued, responsible members of society who are able to use their specialized skill effectively in any healthcare setting. Our students do not have to wait to gain real experience in the workplace. The real experience of nursing begin when they enter the door at School of Nursing, Walayalak University. Teaching and learning methods are based on the United Kingdom Professional Standard Framework. This system emphasized innovation and lifelong learning. Our lectures interact with their class in a relaxed but focused way, which allows students to gain the skill they need to be top of their field: critical thinking, analysis, and group discussion. Happiness in the classroom begin when our students can practice like a professional nurse according to UKPSF.
What is the complication after suctioning of this patient?
His question quite interesting, and his student want to help him to find out the answer.
Left upper lung, yes.
We have to observe about breathing in mouth and tooth and hypoxia because he on the oxygen.
Walayalak University also offers extracurriculum activities, like clinical reasoning, a course for students where they can apply knowledge in practical situations. We offer a unique training system that includes 6 clinics for developing student skills and abilities. One, Wisdom Clinic. 2, I Love English. 3, Personality Development. 4, Brion Clinic. Mind Clinic. 6. Student and Fund Clinic. We are proud of our lecturers, who hold certificated from UKPSF at the Senior Fellow and Fellow levels. Lilac nursing students not only open the door to the classroom but also open the door to gaining real experience supported by a fun, happy learning environment. This Lilac classroom enables nursing students to work as health professionals. Before they graduated, after nursing candidates study with us for full 4 years, they have the right skills to be better than good nurse, a fully registered nurse, a talented nurse who can look after clients.
Today, I am here to talk to you about nursing education in the post-pandemic era. I have divided my presentation into 3 parts. I will begin with information about the School of Nursing, Wang University. Then I will move on to the impact of COVID-19 outbreak to nursing education management, and I will end with nursing education management in the post-pandemic era. So now please take a look at information about the School of Nursing, Wang University. We have total of 774 students in the 3 courses. It composed of nursing assistant diploma, undergraduate as Bachelor of Nursing Science, master degree include of community nurse practitioner, and adult and gerontological nursing. Our school holds 5 years guarantee from the Thailand Nursing and Midwifery Council. It is a proof to the society that we can manage teaching and learning with quality. The students suitable learning in good environment and atmosphere university. There are sufficient resources to support learning, convenient, modern, such as hospital medical center, digital technology center, center for library and education media, and comfortable hotel. We use UKPSF as a framework for managing education, and 98% of teachers in our schools are certified. They are qualified and have the skills to teach effectively. To develop nursing students, be the smart nurse characteristic. The characteristic about smart nurse, we teach the student ability to critical thinking by using clinical reasoning and creating innovation for health, professional communication, nursing practice with virtual professional ethics. We training with the expert teacher, theoretically learning theory and practical in hospital and community, smart classroom and infrastructural media technology, modern nursing laboratory, and virtual facility. Consequently, they always take care by teachers who are advisors, and we also have Smile and Smart Clinic for encourage all the sides, such as studying, life, and working in community. So I would like to draw your attention to the impact of COVID-19 outbreak to nursing education. The epidemic has created a new normal of life, including education management that limited to the process of teaching and learning, such as distancing behavior, reduced direct nursing care. The clinical experience suspended to protect the student from the pandemic. It makes us to develop non-contact modules for education and practice using technology. Then face-to-face teaching and learning were converted to virtual remote knowledge. We provided distance education by using technology as a tool for teaching and learning, such as set online course site for communication between teachers and students. We use Google Classroom or M-Learning as a tool, use Zoom or Google Meet, Line, Facebook group or Facebook Live for teaching intervention and use it for formative and summative evaluation. Sometimes the students are tired. The teacher set gamification for them relaxation. For practical course, we send study materials to students' home, then practice online for teachers' evaluation, reflection, and develop skill until they pass the assessment, such as physical examination course, basic nursing practice. Then this is the example situation. And then another example.
นะคะชุดไทยหมาดๆนะคะและจากนั้นก็ส่งไปให้ตอนสุดที่ในเที่ยวนะคะโดยจาก
and in the for community practice course during epidemic period, we use community leaders, family and community members who want to be a learning resources for students as a community gatekeeper. The community gatekeeper take action as a communicator, coordinator, lecturer, and implementator, or take activity with target groups for nursing teacher and students learning from remote area. And then we set a platform or database or website or something for youth and for the student learning remote area. Now we are moving on to the next point, nursing education management in the post-pandemic era. Certainly, we live with epidemic continuity. It will be a normal life for us. Therefore, nursing education management in the post-pandemic era should be concerned to prepare in 3 issues. First, future plan. Next, teaching and learning process. And finally, knowledge and skill development. About the future plan, a School of Nursing will situation analysis, formulate participatory policy from stakeholders. Flexible plans are therefore essential for future teaching and learning management. We will revise revision of nursing curricula by the various nursing governing bodies is necessary to accommodate and facilitate credible alternative teaching and learning options. Then the future plan, we will use integrated social engagement into teaching and learning, such as our school, we will use capital and potential of the network work with various existing organizations. Our school prepare by integrate social engagement into teaching and learning. We create cooperation with Pakun Municipal in the project of one-stop service COVID-19. It is the practical and learning model to develop, and it was set up to be training center for learning and developing the whole system of care for patients and those at risk, to bring lessons learned to other areas for furthermore use. This one-stop service COVID-19 at Pakun Municipality, it is composed of 6 units and 6 helpers. 6 units composed of the screening COVID-19 and then bring the patient into home quarantine, local quarantine, home isolation, community isolation, and field hospital. And then they use 6 helpers composed of X-ray, oxygen, thermometer, drug, logistics, and database. Our school using home isolation and community isolation as a gatekeeper for cloud community that area-based for education, such as cloud interprofessional education, online community, and online ward. Our plan composed of 3 phases. Phase 1, we use home isolation and community isolation learning team building. After we can set team building, we finish and go to phase 2. It is about create tools to support learning integrated teaching, such as database setting and Line OA or Zoom connection. Then finally, we go to phase 3 about create tools into teaching and learning for set up cloud interprofessional education, to set online community and online ward for teaching and learning strategies. Then about the teaching and learning process preparation, we know that the clinical practicum, aspect of the learning experience is essential. The preparation of necessary resources and infrastructure of online simulation of the clinical in place. Virtual communication, on the other hand, are web-based products and relatively easy to implement and a modernization of the program to include more online and virtual. Then we dropped the project of the driving of central organization network to participatory building healthy community of Nakhon Si Thammarat province. We use community leaders in this project as a gatekeeper for nursing teacher and student learning their community healthcare activity. Through many communication technology, this event used in the course of community healthcare practicum and practicum of psychiatric and nursing management. So, knowledge and skill development that we prepare about nurse need to possess various abilities such as the digital literacy required by the non-contact era after COVID-19 and to expand the boundary of the nursing profession in the convergence of health service with technology. Nurses need to possess digital literacy, advanced nursing technology, and must not forget to be aware of the students and teachers' emotional. So measures such as counseling and mental health sessions should be developed for both staff and students, which will help to minimize and decrease their anxiety and fear. So, to summarize the main point of my talk is the nursing education management will change according epidemic situation. Thank you for your listening patiently and attentively. On behalf of School of Nursing Walayalak University, may I say that thank you for your attention. Thank you very much. สวัสดีค่ะ
Sawadika. Yeah, thank you, Dr. Urai, for your presentation. And I know that Walayalak is a very beautiful university. I have been there in 2019. Very huge university, very beautiful. Yeah. I would like to ask our audience any question. Maybe I can ask the first question. I think during the pandemic, as you mentioned, most of the courses are transformed online, right? So could you tell us how you evaluate the learning effectiveness, including the lecture and the clinic practice? And the other question is, I know you do many of research on community-based. Yeah, so I also would like to know that during the pandemic, because as you mentioned, you also use many of the online courses on the community-based care or whatever. And I also would like to know how do you evaluate the effectiveness, of your transforming the practice or you was transforming your method. Thank you so much.
Okay. Thank you for your attention. During the pandemic, our school evaluated the online learning effectiveness, including formative and summative evaluation. We evaluate online learning lecture effectiveness by assess our student knowledge and their attitude. We use online testing. We set the team of teachers to test that support the student and prevent their copying the information to answer without their thinking. And compare their score before and after lecture. We assign them make a conceptual map, including their self-reflective report between semesters. Though this assessment process we can assess student cognitive and development and support the information for our teacher to understanding and design analytical thinking level development of our students. And for evaluating practical course, we test nursing practice skill that must meet the requirement or that must be in accordance with the requirement of nursing practice of the nursing council that send us with we will teach the student for meet their requirement. We send the nursing equipment such as wound dressing, physical examination tools such as stethoscope, blood pressure, and when two students at their home, and then when the teacher teach online, the teacher demonstrate and stimulate them, return demonstrate the nursing practice for teacher to check online. And the teacher will stimulate them to repeat the practice until it can be done correctly. And in addition, we assign them write self-reflection report so that it will pass on the topic. The practical course that we teach online, such as of the health assessment, primary medical treatment, or adult and older practicum, and psychiatric practicum, and etc. So many thanks for your question. Thank you.
Thank you. So what do you think are the most challenging or difficult part to do the transformation? So what is the most difficult part?
This is very difficult. Very difficult, and many teachers complain. It is
okay.
More than teach face to face, and the teacher provide them a lot of time more than face to face in previously.
Yeah. So how about the students? They like face to face or they like virtual?
The student they want to learn in face to face more than online or remote learning, because they want to face to face with their friend and their teacher, and want to learn in the ward and learn in the lab more than remote. I think in many times in the next year we will meet my student.
Okay, so thank you very much, because our time is almost up. So once again, thank you, Dr. Ulai, to join us today. I hope to see you soon in the future. Yeah, take care. Yeah, see you. Bye.
I hope you come to Walelak University, Nina.
Yeah, I hope so. Okay, bye-bye. Thank you. Sawadee-krap.
我们谢谢乌来博士。
Thank you very much, Professor Wu Lai and Dr. Nina Gao. The last session of the afternoon, we are very honored to have Dr. Judy McCain from Swazia University, Director of Strategic Education. And she will talk about applying lessons learned from the pandemic to medical and health professions education stories from the Frontline. The moderator is Dr. Chung-Ho, Director of School and Medicine, Zhongshan Medical University. Yes, welcome, Dr. Shin.
Good afternoon. Welcome to the very last section of today's online conferences. I'm Dr. Zhonghan Xin from Chongsan Medical University. It's my great honor being able to participate this meeting and chair this section. I also want to congratulate Changhua Christian Hospital and Professor Yang. The meeting today is very successful and very helpful for healthcare profession education. Okay, so the topic of today's last section will be the experiences from the frontline experience of healthcare professional education in UK, where the pandemic is very severe. And we are very glad to have Professor Judy McKim being here with us. Professor McKim is a well-known leader in healthcare profession education. He was the professor and dean of medical education at Swansea University in UK, pro-dean in health and social care of Unitec Institute of Technology in New Zealand, and the director of undergraduate medicine of Imperial College London. With her academic background in social and health sciences, she was dedicated to education reform in health professions and helped a lot of international organizations all around the world. Today, she is going to share her valuable experiences of health professions education in UK during the pandemic times. Let's welcome Professor McKim.
Thank you very much. It's wonderful to be here. I'm really pleased to be with you and to join you. So it's the morning, Saturday morning in the UK here. And my background is some woodland that we own, that we spend a lot of time in. So just to explain why I'm sitting with a dead tree in the background. What I'd like to talk to you about this morning is some research that I've been doing over the last couple of years with doctors in training and qualified health professions staff who have been on leadership programs. And their stories through the pandemic are really interesting, and I think gives us ideas about how we can help support our students and our learners and our qualified staff as we go through. So this research is in the UK, and what we were looking at in this research is thinking about what was it actually like to be working and continuing to learn during the pandemic. We're thinking about how this can have wider implications, and there are certainly some lessons we learned and think about taking those forwards. And I'd be really keen to answer some questions at the end. So this research was an in-depth evaluation of 5 separate programs for doctors in training and qualified health professions. These programs were leadership development programs. Some of them were for qualified health professionals who undertook the program whilst they were still working. That was one of them. The other 4 were evaluations of programs where doctors and other health professionals stepped out of their training or their work for a whole year. And they spent a year in a fellowship where they worked in a host organisation, quite a senior position, and they helped build capacity and do different things. These programs have been going for many years in the UK, and we tend to call them clinical fellow programs, women. But these fellowship programs are supported and funded, and really to support them having an experiential program through that. So our research, we seized the opportunity when the pandemic was emerging in early 2020, really to think about, well, what impact is the pandemic having on these learners and workers from a psychological and an experiential perspective? So we use qualitative methodologies on their education and training, because that was really disrupted. and also looking at the services in which they're training or working, because obviously, as we know around the world, health services have been really disrupted. So these leadership programs were running in England and Wales for doctors and dentists in training, pharmacists and optometrists. There are wider groups in those fellowships, but they weren't in the respondents that we looked at. We also ran a programme in Wales for stroke and neurological conditions. And these were not doctors, but they were specialist nurses, physiotherapists and occupational therapists who were working at senior level in these areas in Wales, across Wales. And we were preparing them to be future clinical leaders. All these people were on the programmes because they demonstrated the potential to become leaders of the future in their respective roles. So they'd been nominated, or they'd applied for the programme and been interviewed and selected. Each of the programmes has a sort of different balance of things, but there's usually some taught leadership course. Initially, they were face-to-face, and like everybody else, we then moved online. So that gave them the fundamentals of what they needed to do in terms of leadership and management skills, self-development, etc. They all had either one-to-one coaching or mentorship. So everybody had an individual coach or mentor. And in the Welsh Stroke and Neurological Conditions group, they had a specific set sessions that they could have. They could have 4 sessions through the year. And that was really, really powerful for them. The other fellows, some of them had coaching through their organisations, but all had a mentor. They either did a visit to different organisations and services, or they were placed in a different organisation. So the clinical fellows all were placed in an organisation, and these range from the Welsh Government, the English Government, the senior NHS executive, Public Health England, Public Health Wales. So all these sort of high-level strategic centres they worked in. The Welsh Stroke group were meant to go on visits. They were supported to go on a visit to a different service, either in the UK or overseas, but only about a third of them managed their visits because of the COVID restrictions and travel. So where they did do visits, they were really good. But unfortunately, we couldn't do all the real visits because of COVID. And then through the programmes, myself and the other faculty provided support for them, and everybody did a work-based improvement project. And that was either quality improvement or service improvement. And that was the whole point of this, that they were actually trying to improve the services that they were working in. So everybody had a project that they either chose or were assigned to. We carried out the research between February 2020 and August 2021. We've literally just written up the last one. We did a questionnaire survey of all participants in the programmes, and there were 125 staff across those 5 programmes. And then we did depth semi-structured interviews of 35 participants, and they were between 40 minutes and an hour long. So they were really in depth and really interesting to do, actually, to have those conversations. And then the clinical fellows all produce a reflective report at the end, and we did a documentary analysis of those reflective reports. Everybody consented to this. If they didn't want to participate, there were no penalties for that. Once we'd gathered all the data, most of it was qualitative data, we coded it, and then we did a thematic analysis, myself and another researcher, manually to get a feel for it, and we also ran it through NVivo as well to pick out the core themes there. So the talk programme that we ran, I think is quite interesting in the way that we modified it, and I think it highlights what we can give forward to people actually in wider undergraduate and postgraduate education. It's what people need when they're working and learning in times of uncertainty, change and crisis. So we looked at 4 levels of training. We looked at the intrapersonal, that was about developing themselves. We looked at compassionate and inclusive leadership. We talked about unconscious bias and how that affects their practice. We looked at the positive psychology and learned optimism. And we looked at emotional intelligence and how we can help to nurture that to deal better with the things that were going on. We then looked at the interpersonal. This is probably the biggest group of biggest focus, really. You know, how do people work in groups and teams? How do they learn followership? How can they influence change? And of course, a lot of stress was going on. So what about dealing with conflict there? At the organisational level, I think people, when they're making service improvements or educational improvements, they need to know the structures that they work in, how they function. They need to learn about change programs, quality and service improvement. We did quite a lot on methodologies about quality and service improvement. We did sessions on project management so that they could think about how to manage their projects and what they needed to do with their stakeholders, communications. And we talked about decision making as well, how decision making is made. And of course, we used make and what was happening as case examples of how things were happening, particularly in such a complex time and complex system. So in the system, we really looked at then, well, how can you make change through the system, and what sort of leadership is needed there? How can we adapt, and how can we regenerate and help recover and recuperate from the pandemic, and also help the people that we're working with? So we adapted all the programs in response to the pandemic. And for example, in the Wales program, I asked the groups, I said, you know, what will help you to help your teams and yourselves get through this pandemic and get through the crisis? Because there was huge impact on, particularly on stroke services, where, you know, somebody would present with a very acute situation with a stroke, then have to go into emergency, but all that was half locked down with COVID. A lot of the inpatient wards were changed and made into COVID wards. The therapy rooms were lost. Again, they were made into acute COVID wards because we were quite overwhelmed in the UK with the hospitals were really overwhelmed. And of course, they were trying to get people out of hospital as quickly as possible. But the community side of things was where they had to really focus their efforts, because actually the time in hospital, we didn't want the people with stroke, obviously, to be getting COVID while they were in hospital when they were so vulnerable. So the stroke services, and to a lesser extent, the neurological conditions, really had an impact on the patients and the patient flow. And as a consequence, it had a real impact on the teams. And so they said to me, can we talk about how can we maintain relationships? How can we build quick relationships when our teams are dispersed or broken up or moving around or new people are coming in? We talked about positive psychology and how to motivate, how to deal with challenge and crisis, what a crisis is, and how you can best work in a crisis. How do you build morale? How do you support well-being? And how do you really support your team through this? Many of whom were actually getting themselves or their families were. So there was huge anxiety around everything. And I think what was really interesting is we kept going. And at one point, I think all of our leadership programs, we thought, shall we just stop them and let everybody go back to clinical? But we didn't. And I think that's one of the big lessons from this, is to think sometimes programs like this, we shouldn't throw them away when we have a crisis. We should keep going, because actually the support that we can give people through their peer groups and through our work can actually help them deal with the crisis and actually deal with their teams. So for me, that was a big message. All of us running the programs were in two minds about whether we should stop or not, and giving people choice to go back to clinical and go on the front line or not. And some people did and some people didn't, but all the programs continued even if people went back. So the evaluation, really positive evaluations of all these programs. They really valued the structure, the delivery, the approach, and also the flexibility that the tutors gave and the host organisations. People were very flexible in this pandemic, and I think we would call that adaptive leadership, and that was really strong all the way through the NHS. They really liked the combination of the taught elements on leadership and management and change, and very, very powerful, the peer and faculty networking, very important, and the coaching and placements and visits work really well. So they are things that I think for leadership development programs, let's make sure we put those in. But what also happened through the pandemic is we really, I think, equipped a group of clinical leaders, 125 people in 1 year, to step up as leaders and managers and to actually keep effecting change even through the pandemic and respond to different service changes. We formed a really strong network of the clinical leaders, nurses, physios, occupational therapists, pharmacists, optometrists, doctors and dentists. So very multi-professional, and that again is very powerful. In Wales, we have integrated health and care services, and for things like stroke, logical conditions, that's really important because actually the pathway of care is very much, into hospital, back in the community with healthcare and social care. And so that whole network is really important if you're going to think, well, how do we keep people out? So this was a word cloud that we did looking at the impact of them, of clinical leaders. We asked them this was from the interviews really, just to say, what give me a phrase or a few words about what it was like. And as expected, challenging, difficult, roller coaster, but also some positive things as well, that there were opportunities, experience, confidence. We gave them journey, pandemic fight, patients and people at the centre here, something about control, how they felt out of control, but also we helped give them some control over what was possible and what wasn't. So I thought it was quite a nice little word cloud. As I said earlier, we're looking at three perspectives. This is the psychological and experiential perspective. And in the middle of this was all this anxiety. This is why I made this one a red one. And different things. This was the one that struck me, that came out. We had to step up. We had no choice. So that feeling of almost being pushed out of your comfort zone and pushed into the front line. I felt like I had to fight my own corner, because if I don't care, nobody else seems to care. If I don't show up, nobody's going to listen. This one was about fighting the corner for the services. I think this was somebody who actually was running epilepsy services and they just stopped because they used the space for their epilepsy clinics. And so that service almost stopped to support people with epilepsy in the long term. But there were lots of opportunities to step up and lead. So that's, if people are supported to lead, they can really step up. It was challenging, but a massive opportunity. It pushed me into a zone. It's given me lots more confidence. I've become much more of an authoritative role within my team and department. So stepping up and thinking about, well, what is that role? They've grown as a leader and they're appreciated with their team. And I think this was the stuff that we did with building morale. And we were all there for each other because there was lots of anxiety and personal anxiety. So you can see the pandemic had an impact on these people, partly challenging, partly getting out their comfort zone, but also with support, people can actually take that forward. And we did a lot of psychological and experiential work with the fellows and with the graduates. Big impact on education and training. as expected, online learning and working was really tiring because all the services, all the clinics went remote as well. So all the learning and all the things. But actually, there were different opportunities to work. And I think we saw that a lot, actually, that we were seeing people sort of redeployed to work in track and trace, work on the front line. So redeployment had a huge impact on the training programs because they weren't training in the area they were meant to, particularly for surgeons. The surgical trainees really struggled there. Our training program was very jeopardized and we had very little support. I think that was actually a surgeon. I was asked to work in a completely new area, but I learned loads. So that was actually a big opportunity. And then, of course, for the projects, if they had to return to the front line away from where the projects were, they couldn't do their projects. But most people did do different projects because, for example, these working in track and trace, they actually did a different project and they joined together to do that and help strategize. So opportunities, but also jeopardize their training too. What we saw with students and the way that we work with students, and it was really interesting to hear the speaker before, is we did quite a lot with medical students. They graduated early to help in the health workforce. In 2020, they graduated in April instead of July. And they'd done all their exams and they actually went to work. They looked after health workers' children. That was a peer-led project. They were working with homeless, refugees and migrant people and groups. And again, as we said, they engaged in test and trace. So I know when I went to have my vaccination, actually, which isn't on here, it was one of our medical students that gave me my first jab. So, we found our medical students were all over the place, all through all the years, which was really nice. The impact on clinical services was very, very dire, I think. The strain on resources was hard to manage. Half my team was redeployed and replaced by junior staff without experience. That's really difficult to manage, isn't it? Our service was closed down as it was seen as non-essential, so my patients with long-term conditions got no support. That was a big impact, I think, and we think that this year, or sort of 18 months, on stroke and neurological conditions will have had a big impact. The other patient need an advocate as well. Non-COVID patients need people for fighting for them, and that's right. If everything, particularly in the first wave, went for COVID, and our first wave wasn't as hard as we thought. The second wave for us was the really bad wave, and so everything was redeployed, and we ended up with empty wards and things. And of course, the people working in the clinical areas that weren't COVID were a bit hacked off, really. We lost essential therapy space as our centre was used for COVID. All elective surgery stopped. Huge impact on services and patients, plus our surgical training. We've got a massive backlog. We've got 5.6 million people in the UK on the waiting lists for elective surgery. So let's just think about the implications on this on other health professions. It's really clear, and we've heard this right across the world, that we need to rapidly adapt our programme in response to needs. I think one of the things that's really important is to provide these safe spaces for reflection during uncertainty and crisis. This is for the learners, knowing that they're not alone and thinking about how to meet challenges, but also for faculty. Sharing experiences with peers is highly valuable. I think I noticed it on the stroke and neurological conditions programme, that when they came together, they almost went, oh, now I can say how I feel, and now I can say what I'm struggling with as a leader because I've nobody else to talk to. Very much of a shift up that. I found myself shifting from a teaching role, giving them tools to do their projects, to very much about facilitating networking and facilitating conversations about the struggles that they were dealing with, and helping to think about solutions and how they might move forward. But our findings from our studies, they really confirm those wider trends, and we've read about this around the world. Anxiety, stress, low morale, even burnout. We need to embed well-being into the core curricula. We need to give people the tools. It's not all about resilience. This is about how do you maintain your well-being and the well-being of people around you. So I think in providing support and the tools people need, and when you're implementing rapid change, rapid policy or procedural changes, you need to have the tools to do that. It isn't just, it's not like steady state where you might have, 6 or 9 months to prepare something. You might only have a week. And so you need those tools. And if we can support people, and I'm talking about leaders here, but I think our students as well, they can seize multiple opportunities to implement meaningful change. And so that personal resilience is important, but also our services, education and health, need to be resilient and they need to be flexible. And getting the balance between those is quite tricky. So stable leadership and facilitation really helps people think about challenges. And I think these were some suggestions for, well, how do we put these things in faculty development and how do we put them in our curricula? How to motivate and support individuals and teams, well-being, positive culture, motivation theory, psychological impacts of crisis, thinking about positive psychology, but also let people have space to recuperate and to reflect. How do you maintain your personal authenticity and your credibility as a leader in great uncertainty when you're absolutely out of your depth? It's really difficult. Let's share practice between individuals, groups, organisations, and let's learn about these changes and seize the opportunities, particularly as we move forward. Something that's close to my heart, and I think, again, stemming from COVID, is really thinking about education for sustainable healthcare, really thinking about climate change, the climate crisis, the impact on health, and put into practice actions that reduce the impact here. So really, our students are going forward there. And thinking about what is it in terms of leadership then? We call it eco-ethical leadership, a moral duty to take care of the world around us. Help people see the world from a dynamic systems perspective. It's not straightforward, it's not linear. Let's think about how we sustain and regenerate ourselves, our communities, our curricula, our organisations. Let's work collaboratively. This is a really good example, isn't it, of us working collaboratively. Let's think about social justice, because COVID has had huge inequalities. It's highlighted inequalities in health and access. And let's think about being compassionate and looking after ourselves and then taking responsibility. So this is a paper we wrote in 2020, which was about eco-ethical leadership. Sort of before COVID we wrote it, actually, but hey. So the last 3 bits are about the lessons. Let's provide stability. So even when things are uncertainty, we need to provide responsive, adaptive stability for our learners. We need to help our educators and our learners to navigate what I call these choppy waters. Let's keep people physically safe and psychologically safe. Let's see things as opportunities. Let's think about new perspectives. Look how everybody's online. We're online now. We're learning online. We're working online. It's not for everything, but it is actually ways that we can actually very much collaborate internationally as well. Let's give people tools so they understand change in the wider context, that it's not just about us, themselves and looking inwards. And then let's support our educators to step up and take leadership. Let's provide them with that confidence. Let's give them the opportunities. So my last couple of slides really then are about let's learn from our journey. Let's acknowledge and respect the past, because that is important. It's where we've come from. We've got to work in the here and now on key issues and opportunities. But what we need to do for our professionals, we need to educate, train and prepare them for an uncertain future, because things are uncertain. And as humans, we're hardwired to work in, to maintain equilibrium and homeostasis. So let's do that in our minds as well. Let's think about, uncertainty, we're going to have uncertainty. So let's learn to live with it. So let's keep what was precious as we move forward. Let's keep what's precious. Let's keep the focus on our students. Let's keep the focus on our patients and our teams and people. And let's get rid of the expendable. Do we need to be sitting in lecture theatres of 600 people, for 5 hours? No, we don't, I don't think. Let's work with uncertainty and change. Let's be adaptive leaders. And then let's think about going forward. Let's plan for flexibility. Let's have hybrid education and workplace models so that actually things are more flexible, because if they're more flexible, they're actually much less risky of toppling over. And that's what we don't want, because we need to provide stability. So that's the end of my talk, and I'll come back to you.
Okay. Thank you, Professor McKim, for sharing your precious experience from the frontline. Okay, so we all know during the pandemic, there are a lot of anxiety and stress. But from your survey, we learned that most of us health care worker became stronger, became more responsible. I think that's a good news. Okay. Is there any question from the audience? Okay. So I have a question. So in your survey, you study many disciplines such as medicine, dentist, nursing, etc. So do you see any major differences in terms of response, change, or challenge between across these disciplines? Thank you.
Not really, no, because I think people are people at the end of the day. And it was one of the questions that we asked. I asked in the interviews, I said, what particularly do you bring to leadership as a physio or a nurse or a doctor or whatever? And whilst everybody has their own skills that they bring and their knowledge, actually, because in a crisis and uncertainty, we're dealing with it as a human being as opposed to being a doctor. Actually, for me, that's where it came down to. And I think if we can look at psychological safety and keeping people well and healthy and giving them the tools they need and the spaces they need to talk about things, actually, they can then do their job. And for me, that's probably, I am a psychotherapist by background also, so I might well say that, but I do think that's the case as well. And I think the frustrations were when they couldn't do their job because, perhaps the services had changed or they'd lost their team or redeployed, or they were put into a COVID ward where actually their real job was they're a stroke nurse specialist. And they've put on they're pronating patients or ventilating patients or whatever. So I think the frustration was that they were losing their specialist skills, but yet they knew they had to, give back to the front line. So I think, and they were worried about their patients. I think that's the concern for their patients.
Okay, thank you. That's a great team. Yes. Okay, so another question is. We know that you have been a very tough year since 2020, but here in Taiwan, maybe we are lucky out or sort of more lucky, because today we have 0 domestic cases of COVID-19 patients. So although we have some pandemic over the 2 or 3 months ago, but we managed to control it is better. So for us, we have experience in short-term change, but can you give us some advice that if it became a very long-term challenge, what should we prepare, both mentally and physically? Thank you.
Thank you. I think that having the idea that people talk about going back to the new normal, but I think the new normal is living with the fact that even if it's not COVID, we will probably be living with pandemics and with the effects of the climate emergency on health. So let's prepare ourselves to live with that uncertainty and to think about, well, things are going to be uncertain. So let's, that's why I talk about the precious. How do we maintain the focus on our learners and preparing them to be safe, competent, caring health professionals? How do we look after our peers and our colleagues so that we can actually function well? And if things do change, that we go with it, we roll with it, and we, like the bamboo that bends in the wind, not the oak tree that breaks. And I think that's really important, that the more flexible we can be and just think, okay, we're working from home this week, then we're set up to do that. So let's get systems that are nice and flexible. And that means the leadership has to be flexible as well. It has to allow people and give them the autonomy to work in different ways and to learn in different ways. So we've almost got to put the responsibility back on people. So I do think it's that flexibility. We call it adaptive leadership. Heifetz and Linsky talk about adaptive leadership, where we take the bigger picture and we adapt to changes as they come along. So we're looking to the horizon a little bit more than perhaps we did. But we've learned so much, haven't we, from the pandemic? We've learned so much about education and how to do it differently and what some of the challenges are. And we've shared ideas about what those can be. So I think as a community of health professions educators, we're very strong and we're very collaborative, and we do share practice. And that's really important. And, so I think if we continue to do that, nobody should struggle on their own, because nothing is unique, really. At the moment, we're all in a similar sea in different boats. So that's how I feel, what's happening. So we're just predicting another wave as our school children and students have all gone back. So they're predicting another wave of COVID over the next few weeks and months. So we'll just lock ourselves back down again. Look at New Zealand, how they've just done that, and then we've got to do that with our organisations, haven't we? If we go back into lockdown, well, we do, and we'll do it this way, and then we'll come out and we'll do this. And it's perhaps that's living with COVID, isn't it?
Okay, thank you for your advice. Okay, Professor McKim, there's a question from the audience. Okay, so Judy, thank you very much for your lovely lecture. What is the most difficult things for you to provide leadership programs in the middle of COVID-19 pandemic? There's a question from the audience. Thank you.
Yeah, well, I mean, all the teaching, as sort of this sort of work, that everything went online, and actually that was at first, I think people were resistant to it, but I've noticed now. I mean, I have not taught a face-to-face group since the 18th of March 2020. I haven't, because I've been at home. I've been at home all the time. So I think people have very much got used to learning this way. But I think the real difficulty for the groups is that their projects that they do, because they all do this quality or service improvement project, their projects, they couldn't do them, most of them. So what we tried to do was look for opportunities for new projects. Say, okay, let's look for something new that you can do that's with COVID. But I just miss the face-to-face interaction, like we all do. We all love to work with our learners, whether they're, adults or they're younger people, whatever they are. So we like to be face-to-face. So that was the challenge, really. And I think the other challenge was that people were so busy that it was hard to get them together. If you're a busy health professional working on an acute COVID ward, then, do you have the time to come out? Do you think it's important enough to step out for 4 hours and do a Zoom session? So that's why we said, what do you want? And I'll provide what you want and what you think you need. And that worked really well. And the majority of people did engage because they were finding it useful. So changing your style, I think, from teaching to facilitation, that's very much what I felt I did. And I felt like I was more a facilitator of a group that just needed to get things out there and then think about solutions. And the other thing I did, which I think is really positive, is encourage them to use their own network and form their own network. And we always do that with groups now. You know, we form WhatsApp networks or whatever, so that people can actually, the group can continue without me being there. And that's very important. So they shared ideas on services. So, for example, one of the things that was hugely needed was early supported discharge from hospital, as I mentioned, because the patients couldn't stay in the hospital because it was too dangerous because of COVID. They were catching COVID in hospital and they'd come in without it. So they did. So a lot of the services went to early supported discharge services, and so 4 of them from the Wales group worked together on a national strategy for early supported community discharge. And that was really powerful. So they worked at national level and they got together. Mm-hmm. Wales is quite small, so we can do that. But that was really powerful. So it was sort of supporting people to do things themselves and facilitating that. I found that shift was a shift that I needed to make. So that was interesting.
Okay, thank you. It's hard to be a very good leader.
Definitely.
It's a challenging, yeah. Okay, thank you again for sharing your precious experience from the front line. Thank you. Hopefully, in the near future, we can discuss face to face. Okay,
definitely.
In the future.
Yes, definitely. That's on the list.
Okay,
thank you very much, everybody.
Thank you, Judy, again. Thank you.
Thank
you very much, Professor McKim, and also Professor Shin. Ladies and gentlemen, the impact and response of medical professional education in the post-pandemic era is drawing to a close. We would like to have Professor Chung-Ho to give his closing remarks.
On behalf of the organizing committee and member of Changhua Christian Hospital, I would like to forward my gratitude to all distinguished speakers from UK, USA, Japan, Thailand, Singapore, and Taiwan. Many thanks to all the speakers for their sharing their great experiences and expertise on medical education, how to adapt to the COVID-19 era. I would like to quote Professor Judy McKim just mentioned. We should respect to the past and adapt to the present uncertainty, and to develop innovative model to face the future challenge. So thank you so much to all the online participants. Today we had more than 500 and around 600 participants online. And through your participation to make the conference become so successful, meaningful, and valuable. And thank you to all the participants. And I would like, on behalf of the Changhua Christian Hospital, I would like to thank everyone again to join the international conference for the celebrating of the 125 years anniversary of Changhua Christian Hospital. And I think this is a quite successful conference. And thank you very much again. Thank you and bye-bye.
Ladies and gentlemen, all the online participants, that concludes our international online conference. Thank you very much for your participation. Let's work together for the better the medical education in Taiwan. Thank you. We'll see you soon in the future. Bye.